Welcome to At the Nurses Station, a podcast for nurses about everything but the patients. Sam and I are here today, and we are going to talk about something that hopefully doesn't get us fired. We already interviewed one of our favorite physicians on how to be a doctor's favorite nurse, and we thought today we would talk about how to be a nurse's favorite doctor. So I'm sure Sam and I will come up with some random things to say. How are you, Sam?
I'm good. Well, I'm good. I worked yesterday until 11, but had to be up quite early to get my kids to stuff. So it's the afternoon. I feel like I could use a nap. Honestly.
Yeah, I could always use a nap.
I'm tired, but good. It's hot out. The sun's shining. We spent the morning at the lake or at the river with some homeschool friends. And so it was really fun.
Nice.
Yeah.
My husband was complaining this morning because my kids have been sleeping in. And so I'm joking that they are just now on mom's sleep schedule because I sleep in every day if I can. And yeah, one of them didn't get up until 12:30.
Holy smokes. That's quite late.
I mean, good for them. It's summer. I don't care.
That's true. Yeah. And it's just so hot. Like there's no reason to be, out and about earlier than necessary. Yeah. No, that makes sense. How are you?
I'm good. So I'm working today and tomorrow, and then I'm off for a week, taking some vacation time over the 4th of July. And we'll be out at the lake and fireworks, and hopefully nobody has to go to the ER.
You won't be there. So, yeah.
No, fireworks season. We live in an area where fireworks are allowed on the lake because it's reservation land. Which is a good thing that we get to experience that. But at the same time, we get a lot of fireworks injuries. So I'm a little bit, mom bearish around the fireworks and the bonfires and the water, and they're all ER-y kind of situations.
Like the first patient that I had, like pediatric patient at a different facility, that made me like, I don't know what you would call that feeling where you're like, oh, wait, I might not be capable of, like, you need to get the grown up in the room. Like this isn't, that feeling was the kid that was pouring gasoline on a bonfire. And of course how it like goes up the stream of gas, right? And then the can that he was squeezing lit on fire. And so we had to intubate him and transport him to the burn center. And anyway, to not get into, and then the mom refused to go in the room because she couldn't look at him.
Yeah.
Oh man.
Burns are different. Burns, I think, unless you're working at a burn center, I think burns make all nurses a little nervous. In reality, there's not a whole lot you can do. You cover them and give them fluids and ship them off, but it does seem a little overwhelming.
And I feel like, is it just me or did the protocols change like a decade ago?
I wasn't ER a decade ago, so I can't tell you that.
I feel like it was like, don't touch them and don't do anything. And then it was like, just put like a sterile drape, like a surgical drape over the top of them. And then it was like, now do we do wet? Do we put like a wet sterile?
No.
And then it used to be that you didn't debride it, but in our ER, we debride them all the time.
Well, okay, that takes me to a doctor story. And this doctor does not work with us anymore. So if our wonderful doctors are listening, I'm not talking about you. But we had a chemical burn, and he told us to soak the hand in warm water, which is completely not what you do. And so it was up to us nurses to be like, I think we should probably call the burn center and get some clear direction here.
Guidelines.
Yeah. So those stickers that always say, love your nurse, they are keeping the doctors from killing you. It's not always wrong. I mean, that kid wouldn't have died from it, but it probably would have made the burn a lot worse.
Burns, they're cool like in the sense that you might have like a critical patient, but it's always that kind of cool where I'm like, oh, do I actually remember what I'm supposed to do? How about just an IV and pain meds? If we start there, then we can figure everything else out. But I don't know. And then the airway, I think, yeah, I've had 2 airway burns, that kid. Mm-hmm. And then the stereotypical friggin' NCLEX question, no smoking with your nasal cannula on. And he was, and his oxygen lit on fire. And I also transported him to the burn center that's like an hour, but we rode in the back of ambulances all the time. So it was fun, but it
always cracks me up when you go to like a nursing home. I don't know if they do it anymore, but when I was in nursing school, I worked in a nursing home as a CNA, as most of us do. Mm-hmm. And you would just have all the little people sitting in the courtyard smoking with their oxygen on. And I'm like, why are we allowing this? It seems like a not good idea.
I thought we all knew better, but no. Okay.
We're just going to let them do whatever they want, I guess.
Yeah. Well, yeah. Okay. So the chemical burn doctor. So you had a concern. Mm-hmm. You got other advice. How was it received?
Well, this doctor was... he had a lot of jobs in a few years of being a doctor, which is never a good impression, I guess. Mm-hmm. So he actually listened to us, but it was almost like this bebopping, oh yeah, sure. Okay. Whatever you want, which is not what I want to hear.
I have now connected the dots. Okay.
Yes. Okay. And so I don't think I was in charge that shift, but I think between the charge nurse and I, we kind of just did whatever we wanted or what was needed, and then just told him what we were doing. And he was fine with it because then we took control of the situation.
Right. Which is what he preferred.
Yes.
You're right. Okay. So we're talking about doctors that, I mean, this is obviously our own opinion. I would imagine that there are some nurses that like different kinds of doctors than you and I do, but my guess is that we prefer the same. We have the same type, if you will. So I kind of wanted to start out. So I like a doctor that can take a question, right? Or take a concern and not just disregard it and say, no, this is what we're going to do. And which is not to say that I'm right all of the time. Right. But I want do you hear my question? Do you hear my concern? Even if it's not needed or I'm wrong about it, you thought about it. And then you're going to tell me why it's okay. Right. Mm-hmm. Or why we're doing that. I like that, obviously. And I don't know why there would be any nurse that wouldn't, but I say that. And then my most favorite doctors that I've ever worked with are grumpy and don't like being questioned and are just like, yes, no, rah, rah, rah. And those are the ones that have been most in that I just have loved working with after a few years. So maybe I'm a little walking contradiction. I'm not sure.
Yeah, I was just going to say, I feel like you're contradicting yourself. You want to be able to ask a question and have them respond to you. But you also like the ones where you ask a question and they're like, no, Sam, we're doing it my way. Go along. And but you trust those doctors.
I was going to say, I think that now that I thinking about it, I've been snapped at by those doctors, but I was a very, very young nurse, was probably asking really dumb questions, honestly, just waste of the doctor's time. And I should have known better, but yeah, I trust them. Yeah. I trusted those doctors. So I probably had less to ask.
Yeah. I think that, if doctors were listening to this and we're trying to teach them how to be our favorites, I guess the number one thing to start with is being competent and proving yourself to me that you know what you're doing and you have a reason behind it. And that I don't need to question you.
Yes. But how do you do that?
By doing your job. So yes, you and I like the same kind of doctors. I think that For me, I love doctors that are proficient and they can work through the easy patients just as quickly as they can work through the hard patients. I can't stand when I have doctors that are like spending all this time with these, level 4 patients, or they're putting them to the side to only focus on the critical patients. So then we can't take care of the less critical ones. That's probably very ER specific. It's like a time management skill that they have to have as doctors. Because if they're not doing their job, I can't do my job.
I guess I'm seeing 2 different scenarios. There's like, if you are a new nurse in the department, and not just like, but if you're the new person in the department, what kind of doctor am I going to be drawn to? Like, who do I know that I like? But if the doctor is the new person in the department, winning the nurse's favor is going to look different in that situation than in. So like, if I'm new to the department, I want to find like what doctor knows what they're doing. Like you're saying, they put in orders appropriately, even though they have this like code going on or critical trauma or whatever. They go and do their assessment, put their orders in, let the nurse do their job. And while we're getting all of the diagnostics and they have a second, they're putting orders in on all their other patients, right? Mm-hmm. They're still keeping up there. Honestly, I like a doctor that's not like too much in the mix with the nurses.
Mm-hmm. Like at the nurses station, I like, having a good rapport with the doctors and we can joke around and there's humor. But then when we're at the bedside, I like when there is a delineation of them walking in and, okay, I am Dr. So-and-so, tell me what's going on. We tell them, okay, they do their assessment, they give us orders, and then they get out. Like, they don't need to stick around the room and make sure that we're doing what they want. Does that make sense?
Have you ever experienced that? Like a doctor that's like checking in on you like that?
Yeah. Or maybe not checking in. Checking in, I think, is the wrong vibe that I'm trying to say. Like, they feel like they need to stay in the room to continue monitoring instead of like stepping away and letting us do the orders that they just asked us to do.
Yeah. I like that. Yeah, no, I agree. And because I say that I like a doctor that's not too much in the mix with the nurses. And then I think a couple that we work with now, and I'm like, oh, I love like chit-chatting with them and being part of like, hearing what's going on with their families or what they're doing on vacation. So I do, but there's like a different vibe. Like if the doctor is just too in with the nurses, I'm like, that your job is different than ours. There's like, I like that separation. Like when we talk to Dr. Rochelle, I'm like, I like the hierarchy. Like you are above me in this environment. And I actually really like that structure. I find like safety and security in that. And that might be what I'm saying. Like if there's a doctor that I trust and is competent, like one that I had, this was when you were talking about things that you learn when you look stupid. He intubated a patient and we didn't have RT. So he asked me for a 10. Well, I just pulled out the flush that was in my pocket. And to which he grabbed it and said, "What is this?" And literally threw it on the other side of the room. And I was like, well, what do you want? He's like, I just need a 10 ml syringe, not a flush. I was like, oh, because you don't want to have water sitting in their trachea? That seems reasonable. Got it. But like, he's a doctor that I trusted. And, anyway, so it's just kind of like, oh, I want to be able to question you, but I trust you. I don't know.
Yeah, I think nothing will irritate me more than in a critical situation, I feel the need to step up and lead the room.
So
because the physician is not doing that.
Oh.
So if I'm in there and, we are taught very sequential things to do in a code situation, right? If those things are not being followed or we're not calling out what's happening, that's the physician's job. They should come in, command the room, give people their roles, all these things. They should be leading it. And if the room's not being led, then as the senior nurse, I feel like I have to then lead the room. And that to me, it doesn't run smoothly because not everybody's going to listen to me, right?
Yeah.
Or they shouldn't have to. So one of my biggest things, and I guess that goes back to me saying, like, I just want you to be able to do your job so I can do my job, is we have one doctor that is fabulous at this. And when she comes in, it is like, everyone quiet. Let's go through our roles. She'll introduce people, like if we have time, like if the patient isn't there yet.
Yeah.
And very clearly, role delineation, does things in a very sequential order that follows the textbook. There's a reason why it's supposed to be done that way. That is just perfection.
I do like that. It doesn't actually bother me so much if a physician isn't being aggressive. Well, I guess I don't take it necessarily as passive. I take it usually as like, okay, the patient's not as critical as maybe I was anticipating them being. Like, I'm reading the doctor and wanting to act appropriately after that. So if the passiveness is appropriate for the patient situation, doesn't bother me. I think what frustrates me more is when I have maybe a newer doctor or a doctor who's not as confident in what they need to do. And instead of expressing that in some way in the room, like asking the senior nurses, what do you see? What is your assessment? What do you think we should do? What does the PICU need? Or, stuff like that. They just don't communicate at all and then leave and then put in a whole slew of orders that sometimes also don't make sense. That, I would say that is my least favorite combination. What would you call that in like a colloquial sense when you're fronting? Is that what that is?
Sure. Yeah. Or the doctor. So like if we get away from the critical patients, it's on any patient when you have the shotgun approach and where every single patient is getting a full workup because the doctor is not competent in their assessment skills to rule some things out or start slow. Every single patient that comes in with right lower quadrant abdominal pain, maybe doesn't need, on a 4-year-old that is terrified of being there, maybe send them to ultrasound first before having us do an IV and labs and all the things. If they have a history of constipation, hey, maybe we get an x-ray first and then we go down the blood work trail. I think that drives us all crazy when you come in and it's like everyone has a workup today and you're looking at the providers and you're like, of course they do. And I'm just going to be doing full workups on every single patient I see. And that to me shows a lack of confidence.
Yeah. So as a new doctor on the unit, if that is what you're doing, then I think instantly that's like how a way to not promote confidence in your nurses. If you're new to the unit and, whatever, you might have a lovely personality, be very good in codes, but your day to day, yes, you're ordering full workups on everyone, then I'm kind of like really? But if I'm new to a unit and I see, it'll take me a minute, right? Because you're like, oh, do you not order workups because you know what you're doing? Or do you not order workups because you don't know what you're doing? And so I think as far as being new to the unit as a nurse, I think a good quality in a doctor is to be patient with the questions as the nurse is trying to get her or his feet wet and be like, oh, well, do do you like these orders to go together so that I know what is the process that you like, something like trying to figure that out. But if a doctor is new to a unit,
I know, I don't envy them because nurses are hard to please. So especially those of us that have been doing this for a long time, you're going to get questioned. And I guess my advice is have an answer ready. Like if you get questioned on like, hey, can you explain why you ordered X, Y, and Z? And you go, not a good answer. Not a good start. Not a good start on being my favorite doctor.
Okay, so is a good answer, well, where I trained, blah, 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 blah.
Yes. Well, and so here's the thing that we do have to realize is that physicians go through so much training. Like their schooling is intense. And so I have no doubt that you're smarter than me on day one, but not in real life. Not like not at the bedside where I've been for 20 years. You know, if you're doing everything by the book and you can explain that to me, then that's fine. That just means you need more experience, you know? I don't know. I feel like it's very hard to get on the nurse's good side.
I don't think so.
Well, some people it is.
I feel like I'm not that hard to please. What?
That's funny.
Well, so as like, I don't like that answer. It drives me just nuts. Like, hi, I put this, this is, let's see, Zofran. We have standing orders for Zofran. I put in a Zofran order and then a different order gets put in. And I go and say, hey, like the dose on our standing orders is this. It's based on like these kilo parameters. Are you not okay with that? Well, where I trained, we do it this many milligrams per kilo. Well, that's cute and like super exciting for you, but it's like this has been an established facility for a long time and I have orders. Can you not just like...
And that brings up a good point of doctors and nurses, but specifically when doctors are dealing with nurses, like know which battles to pick. Because if you're battling with me over the dose of Zofran, that's going to rub me really raw. And I'm not going to then pick my battle with you on something more important potentially. So like what Dr. Rochelle was saying, like nurses are your safety net. Like we are there to double check everything. So if you're going to argue with me about the dose of Zofran, like good luck, because there are a lot of things that we could disagree about. Zofran should not be one of them. I actually worked with a physician in the NICU one time, and I had a baby that was constipated and was so uncomfortable and just kicking her little feet and belly was all taut. And I went and asked a provider for a suppository. And she's like, well, there's these new studies that we shouldn't be giving suppositories, blah, 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 blah. And she was a mid-level practitioner. And the provider next to her said, go ahead and give the suppository. And I was like, thank you. And the provider told me later, she was like, I just had to have a little conversation with her that like, if a nurse is asking you, they've been thinking about it for a while, or they've been dealing with this patient problem for a while before they're coming to you. And if it's something little, just give it to them. That is what they have assessed that patient needs. And that is not what you should stand your high ground on.
Yeah. Right. Because it says, I guess, like maybe two things. One that I can remember that I was thinking is like, what you're telling me is that now I have done everything wrong for all of my patients from this point all the way into the past, right? And I don't want to be told, like, no nurse wants to hear that. So you kind of just like set me up for failure. And two, it's kind of like the rug being pulled out from underneath you a little bit. Like you were doing your job, you were assessing your patient, you're using your NIOs, or you had come up with a plan that was appropriate that you could do. You went to your provider, and then all of a sudden you're told to something reasonable, no, because
that's dumb.
Yeah, exactly. And you're like, well, okay, then you just manage your, so like with the Zofran dose, the other thing that it makes me see is like, well, then we don't see anything the same. So there's actually not no way, but it's harder for me to check you as your safety net because we clearly like don't have the same parameters. So I guess if I'm going to come and ask you to verify the dose of Keflex or make sure that you actually wanted that much Vanco, I mean, I'm going to get attitude from you. And also, I don't actually know how you make decisions. So it must be right because we don't make decisions the same way. And I find that just so frustrating.
Yeah, it is. And, back to what I was saying about like, it takes us time to go ask the provider questions. Like I've usually done everything that I can do in my professional scope before I come ask you for something that I need from you.
Yeah.
And now there are bad nurses out there that are going to come to doctors with ridiculous requests. And so I can see that part of it too. But like, if you have a strong nurse that clearly knows what they're talking about, like, do not just shut it down. I mean, have a conversation. If you truly don't want me to do something, then you say no, because, and then I'll say, oh, okay, that makes sense. Thanks for letting me know.
Well, and you don't just start, I agree with you. Yes, I do want to pull out the not good nurse. And I don't want to say it that way, but I have, even our department, I see our poor doctors get like badgered by some of our nurses with like throwaway comments and random pieces of information and not like a solid, I need your attention in an SBAR format. This is what I'm telling you, to have like a really concrete conversation about something. And I understand why that's frustrating for them. And not that anyone has asked me, because I would tell those nurses to stop it. Like I can see how that's hard for them, but we're just going to say the nurses are their best selves in these scenarios.
Yes.
And take that. It shouldn't, like when I come and, ask, oh, well, did you want a bolus with that line in labs? When the answer is just no, because blah, 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 I really actually think the first answer should be, oh, well, I didn't think they needed one. Did you see something? Or do you feel like, and sometimes I'm like, oh no, they just usually go with like all of those orders. So I just thought I'd ask.
Yeah.
Because I think maybe not the best nursing practice, like I could be more thorough or whatever. But asking me why I want it, I think is a reasonable question.
Yeah.
And starting there and then going to, oh no, I actually don't think it's necessary. Oh, okay, sweet. Well, never mind.
Right.
Not a big deal.
Yeah. Yeah. When we question orders, we have a reason. Like I'm not just willy-nilly saying, are you sure that those are the orders you want? Like that sounds ridiculous. I'm questioning an order because based on my experience, I see something off. Or based on my interaction with that particular patient, I have a better idea of how we might get the information than they do. Mm-hmm. And I want to be heard and respected and have a conversation.
Yes. Or I have concerns about the patient, like in like just my ability to do your order. Like I appreciate that you want a urine bag, but you're going to want a culture if it's positive. So can I just do the catheter? Well, we might not need the catheter. I appreciate that from like a textbook standpoint, but from an actual person who's doing the job, You're going to make, like, we're going to wait 2 hours for the urine bag to have urine in it. It seems like it's going to be bad because this 2-year-old has a fever and, you know, hasn't been peeing a lot and doesn't feel good. So then I'm going to have to do a catheter anyway, like 30 or 45 minutes after they peed so that there can be urine in their bladder again. Like, I don't, like, just work with me here. I appreciate that you don't want to do a catheter unnecessarily, but everything we're doing could be unnecessary. I don't know. That's
right.
Yeah.
And that's kind of that shotgun approach as well, right? Where it's like, we're just going to do urine and blood and a nasal swab and, you know, and a throat swab. Like, can we just narrow it down and maybe start with the most likely scenario?
Right. With like a good assessment.
Mm-hmm.
Okay, so that's like orders. I would say, I think a lot of like what Dr. Rochelle talked about, obviously our communication should be civil and in real language and polite and easy, right? I don't think there's any argument about, like, everyone kind of knows that. Some physicians are a little bit short, and that's like, that's fine. I get it. They're doing a lot of things. What are some other things that I can think of? So many things, not so many specific actions or behaviors that if once it's done, I'm like, excuse me. I'm trying to think of like some more positive ones. I'll give you one negative one and then you can go. Interrupting my triage. Oh, if you want to come and be a part of my triage, I don't mind that at all. That's great. Like, that'll save us all time. But when you walk in and say, oh, I'm Allison, the nurse practitioner, what's going on today? And I'm in the middle of like asking about their last menstrual cycle. I'm like, okay, cool. Sweet. See you later.
It's disrespectful.
Yeah.
It is. Like, I would never walk in the middle of your assessment and be like, oh, by the way, do you have any allergies? Okay, thanks. Right? Like,
No.
I think one positive thing that Dr. Rochelle talked a lot about was introducing yourself. So we have residents, and I don't know who you are. I don't know how far into school you are. I don't know anything about you. And so if you just walk right up to me and give me an order, I'm like, excuse me, who are you, Doogie Howser? Like, and I get that they are afraid of us because that is probably something that I would say. But I think that if you walked up and you said, hi, I'm Dr. Stephanie Jones, you know, give me your name. You know, I'm third year resident. I new on your floor. I just saw this patient and I was thinking XYZ. That would be amazing.
Yeah.
Because then I could understand who I'm talking to and not just go over to my provider and be like, who is this? Like, I'm not going to just take orders. We once had a psych patient impersonate a doctor in our unit. So guess what? I'm a little leery of people in blue scrubs.
Yeah. Yeah. That is a good point. And I know we have had med students that I do specifically remember coming up and doing that. And they would come out of the room and say, oh, which nurse has this section, whatever. I'm going to go put orders in for these things. Oh, okay, great. Nice to meet you. Thank you. Like, yeah, that's great. That works for me. Let's see. I also like it when a physician kind of gives me like, and I think this is true of the floor too, in like a longer span. I love to know the plan. I love to know like, what is our long-term, because I don't like the shotgun approach. So tell me, well, I don't really think that they have an appy, but nothing else really like jumps out at me. So we're going to start with the ultrasound and we'll go from there. Oh, sweet. Okay. Great. Then I can kind of keep the doctor more up to date on like maybe the specific pieces of information that they need. Like, oh, then mom happened to mention that she said that it hurts when she pees, but you know, or like, I don't know. I mean, that's just such a like specific example. It doesn't usually happen as cleanly as that. But if I know what you're looking for or what your plan is, I can usually be more helpful in that instead of this tug of war, weird fighting. Yeah.
Or just be like really real. So like I've said, why are we getting an MRI on this patient? And I've had a provider say, because that family is not going to leave unless we get one.
Yeah.
And I'm like, oh, okay. We're just giving them the menu and letting them pick. I get it. We have families like that come in that are just going to be horrible, insistent until they get what they want. So if you just let me know that, then I know why you're ordering it when, I'm looking at the chart saying this does not need an MRI.
And when I walk back in that room to give Tylenol or do vital signs, and all of a sudden the family is, so why do we have to wait 3 hours? Well, because that's how long MRI takes. Instead of being like, I guess I don't really, I don't know. Let me find out for you. Like I already know. Let's see. Something else this is also about triage. When you don't read my triage note, when my triage hasn't been interrupted, so you didn't come in to hear it with me, but I have just sat down at the computer to start putting my stuff in, and you bebop in the room. So clearly, like, nothing that I have to say about this patient matters to you. Then you just do what you want to do, and I'll just do what I want to do, and maybe it'll work out. Yeah,
there is something about, again, the respect, like, because there are already like some patients and some families that are asking why we're asking the same things 3 times. And there is a very specific reason why you get asked at first nurse for the quick down and dirty. You get asked triage, which is a little more deep. And the purpose of those is so that when the provider goes in, they are prepared and can go in and say, so I hear this is what's going on, not just ignoring what we just did and saying, so tell me why you're here. Like, that's frustrating for them and for us.
Yeah. And I do think a lot of the providers still start with that, like, tell me why you're here, which I actually think is okay. But at least they can go in with a little bit of like the other day I offered parents like Tylenol and Zofran, and they were whatever. And they're like, well, we just really want to talk to the provider first. And so I put in my note that they had refused this medication, or they declined to have it before speaking to a provider. And then all of a sudden those orders were in from the provider. And I was like, oh, well, did you go in the room? Oh no, this just seems like what they needed based on, their vital signs. And I was like, right. I tend to agree. But they don't want it.
Again, the shotgun approach of like, I'm just going to see the chief complaint and I'm going to put in orders before I even go in the room.
And that was actually a provider that I really like and get along with. But it just, and even more than that, even outside of the patient care, maybe other personality types wouldn't feel so bad about it. But it's like, well, I take my job seriously and I try to do a really good job with triage. And I like to write a triage note. Like, I have a good triage note. And then you don't even read it. Then why am I here? I don't know. How else can you be a nurse's favorite doctor?
I think my favorite doctors can take a joke and take a little bit of ribbing, so to speak. And this might be more of a charge nurse thing, but like when I'm sitting at the charge nurse desk where we work, it's right across the table from the providers. So we're talking all the time. And if you can't joke around with me, then that's just not as fun. But I like to, make fun of doctors a little bit and have them make fun of me. And we laugh and then just have, again, clear communication of what the plan is moving forward. One of the things that a provider did to me one time when I was in charge was micromanaging where I roomed patients. And I was hot because they were just like, well, just leave that patient out in the lobby because they can just blah, 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 blah. But then said, but can we go out there and give them fentanyl?
No.
Pain. And I was like, no. And so then I roomed the patient and had that provider actually say to me, why is that patient back here? I told you to leave them in the lobby. What? And I was livid. I was just like, okay, this is my job. That's your job. I'm not going to leave a level 3 who needs fentanyl in the lobby. Like, that just doesn't work for me. But yeah, so a provider who's telling me how to do my job is infuriating.
I have no arguments here. I don't know that I've ever had it quite so well. Doctors tend to be less well-versed in hospital operations.
Yeah, they just assume that whatever concoction they come up with is going to work in the hospital.
Yes.
Yeah.
Or whatever they want done in the ER is just going to be done. And you're like, it's not an ER thing. We just don't do that here. Like, I do feel like Dr. Rochelle is an exception to that rule. He seems very finely in tune with lots of, and I think he's just been around a while. So I actually find that very funny about him.
Yeah, he'll just be like, well, just call the surgery center. They can come over and do X, Y, and Z. And it's like, no, they can't. And then he'll call them, and they surely will.
They sure will. I watched him one time get in a little low-key spat with CT, and the mic drop was, well, I wrote the protocol, so that is how you do it. And I was like, I guess I'm going back to CT. See you in a minute, Dr. Rochelle. But I do love that. I do love one of the things that grumpy, personable, new, old, from your department, from a different department, and a doctor that backs up their nurses. Because we defend the doctors in the room all of the time, because we're constantly asked questions about why things are happening, how long they're going to take, what the results mean, why haven't I seen a doctor yet? Like all of the stuff. And it's, even if it's not a doctor that I particularly care for as a person, like, I'm going to defend you. Like we're on a team here. And so having doctors that kind of like throw their nurses under the bus or don't back their nurses, in a variety of ways, right? Like blaming the pain or whatever horrible is going to happen on the nurse because we're the ones that do the procedures, demanding that they need all of whatever they ordered right then. Like, sometimes you just can't get all of the blood, and I'm really sorry, but did you need the send-outs done today? Like, can we be helpful to each other in this regard? Or like, I'm sorry, that mom and I just didn't click, and it's a little bit tense in that room, and I'm sorry about that. And having a doctor that you know is going to go in there and back up what you said, that might be my number one characteristic. Yeah.
And I mean, and you might not agree with this, but I do like the friendliness of a provider and a nurse. Like, I do have to be able to like have fun with you and, talk about, our kids or what you're doing this summer or blah, blah, blah. In the slow moments, like that's really nice to just like have just in those moments, not a hierarchy, right? Like in those moments, like we're more friends, and then we walk into the room and we can play our roles. But when we come back out, we can discuss things as like coworkers.
I'm not saying that I don't like a friendly doctor. And even the doctors that I say are like, quote, grumpy, like over years of working with them, you get to that point where you have that like personable relationship. So I do appreciate that, and I value that. I will say what makes me uneasy about having that is what I have seen is that a lot of nurses can't handle it. So what you're describing, once that split happens, once you walk into the room or you have something real that you need to talk about, what I have noticed is that some nurses can't differentiate that. And it's not most nurses, but there's just enough of them that makes me uncomfortable for the doctor, and it makes me uncomfortable for the friendly relationships that I have with them, that they may misinterpret my friendliness or like a personable relationship that we have, for me misunderstanding my place in those specific situations.
Yeah. And unfortunately, I mean, sexism is still very real. And we have a lot of young female doctors where we work. And So I feel like in front of families, in front of patients, like you need to say, hi, this is Dr. So-and-so, and you are calling her by that in the room. Like we don't stay on a first name basis when we're around patients. Like the doctor needs, or the patient needs to know who the doctor is. Mm-hmm. And I feel like that's just respectful and it's safe. Like, mm-hmm. So the families need to be talking to the doctor, not to me right now, or not to our male CNA that's, or a paramedic student, just because it's a man, that drives me up the wall.
Mm-hmm. Mm-hmm. No, and I mean, I usually always refer to them as doctor, and in our other episode, I said that, well, because that's what they are. And I don't mean that that's all they are as a human, but that, like you said, they've gone through a lot of training. It's not easy to become a doctor. It's probably not easy to stay a doctor, quite honestly, either. And so I think that they've earned that. I think they've earned that title. And in just broader society, when you call someone that, it is a term of respect, and they get a little social bump from that. We do work with a lot of mid-levels, though, and I think all these rules apply for mid-levels the same as doctors. Absolutely. But I will say, if they walk in the room, I'll say, oh, this is our provider, Ashley. Right. Or this is our nurse practitioner, so-and-so. So I still try, even though we're on a first name basis with them more often, I usually try to introduce them with that title.
Yeah.
But it is a respect game in both directions. And it's kind of like, I just have these measly little nurse pittance to offer you. I have my triage notes and I have my IV starting skills. And sometimes I have a better rapport with the parents than you do. Just take what I have to offer and don't be and I have my NIOs, don't hate on the little bit that I have to offer you. And you might actually find that I'm a reasonable ally and right. A good tool to have in your toolkit when you really need it.
Yeah. I think overall, the idea is just mutual respect and understanding what the other side brings to the table and using both of our skills together that is best for the patient.
Yes.
I mean, if we could all just do that with every patient, that'd be great.
Right. If you want to bring free food because you make more than me, that'd be okay too.
We have one provider that always fills the candy drawer, and God bless him. When you come in, I will check the candy drawer before I even see who the doctor is. And if it is filled with chocolate, Reese's and Hershey's and all that, I know who's working. And I am very excited.
And is it terrible to say, in the same way that, my friend that's going through nursing school, I told her, I was these are don't sit down in a chair until you're told that you can sit in that spot because you don't know who's sitting there, and bring donuts. Just when you go to a clinical, bring donuts. I don't care what time of day it is. You need to bring some. For any new doctors out there, it is never going to be to your detriment to bring a box of donuts or a bag of candy. We are simple creatures, us nurses. We need to pee more often. We need to eat better food, and we're usually hungry. So we will eat the crap. And if nothing else, it just kind of opens up that you see something sitting, you're like, oh, who brought this? And somebody's like, oh, it's it's our new resident. And you're like, oh, hey, thanks, you. Yeah. It just brightens it up a little bit.
Absolutely. Yeah. Food for nurses is always a good idea.
Yeah. So you can't go wrong with that. But yeah, I don't know. Hopefully that's helpful. And hopefully it's helpful for nurses too, to think about what qualities they could encourage in their doctors, either showing it to the doctors themselves, or if they have a relationship with somebody in the provider role, kind of talking about those things at a UBC, or I don't know, because if I could go back just really quickly to what we're talking about with Zofran or the suppositories, you can't just change practice on that day for that one patient. If that is a practice of your unit, you can't just say, well, new research shows, it has to go through more people than that. And it's very unsettling to a nurse to have those things just changed on her constantly. So go through those channels and be kind to us. We're just trying to fit into our scrubs and make it work on time because we had to make dinner.
That's right. That's right.
Okay. Anything else?
I don't think so. I think we're good. I'm going to head off to work and see which doctor I'm working with today.
Oh, well, I hope it's one with candy. All right. We'll see you next time at the nurse's station.
Bye, guys. Hey guys, this is Kelly from At the Nurse's Station. Sam and I would like to remind you that the views and opinions expressed on this podcast are strictly our own and do not in any way reflect the position of our employers. This podcast is for entertainment purposes only and in no way should be considered medical advice. As always, consult a qualified medical provider for questions regarding your health or medical conditions. We hope you had fun listening to us today, and we'll see you next time at the Nurse's Station.